Welcome to this Empowering Providers to Empower Patients EPEP program. I'm Dr. Nicole Rochester. EPEP is a patient empowerment network program that serves as a secure space for healthcare providers to learn techniques for improving physician-patient communication and overcoming practice barriers. In this Myeloma Healthcare Roundtable, we are tackling the patient-provider partnership in multiple myeloma treatment decision-making. Some of the topics we'll explore today include aligning treatment goals and quality of life preferences among myeloma patients, care partners, and their providers, sharing healthcare provider to provider best practices and real-world strategies to reduce treatment burden and optimize outcomes, recognizing and addressing differences in treatment priorities between patients, care partners, and clinicians, and applying these insights to clinical practice. It is a privilege to be joined by Dr. Sikander Ailawadhi, Professor of Medicine in the Division of Hematology Oncology at the Mayo Clinic, Florida. Dr. Ailawadhi's career focus includes the treatment of plasma cell disorders, multiple myeloma, Waldenstrom's macroglobulinemia, and chronic lymphocytic leukemia. His research focuses on understanding the epidemiology and pathophysiology of these disorders, evaluating the benefit of various therapeutic strategies in different populations. Thank you for joining us today, Dr. Ailawadhi.
Thanks for having me.
We are also joined by Dr. Craig Cole, a board-certified hematologist. Dr. Cole leads multiple clinical trials in multiple myeloma and has worked extensively with patient advocacy groups to empower, educate, and bring equitable care to everyone. Thank you so much for joining us today, Dr. Cole.
Thank you for having me. Thank you.
We have a lot to discuss as it relates to the patient-provider partnership and myeloma treatment decision-making. So let's start with aligning treatment goals and quality of life preferences among myeloma patients, care partners, and providers. So I'm going to ask this question of each of you, but I'll start with you, Dr. Ailawadhi. In the context of an increasingly complex myeloma treatment landscape, how do you approach shared decision-making with your patients?
Dr. Rochester, you're asking such an important question, and thanks a lot for starting there. As you rightly point out, the treatment landscape of myeloma is becoming increasingly complex. In fact, if you ask 10 quote-unquote experts on myeloma of how the treatment would be, you'll probably get 11 to 12 responses around them. So you can imagine that when patients who have just been given this devastating diagnosis, along with their caregivers, are trying to negotiate that path of decision making, it can be quite complicated. So the way I approach it in my clinic is, I think before getting to the treatment part, to try to build a bond and a relationship with the patient and their caregivers, make sure that they understand about the disease and the diagnosis very well. They need to understand those ins and outs first. What are the markers in myeloma? What is the risk stratification? What is the disease stage? What are the symptoms they're dealing with? Just to make sure that we talk to them on a person-to-person level, trying to bring it down to their level of understanding. And then when we are starting to talk about the treatment options, the way I approach it is I try to lay it down by categories and kind of buckets of treatments with some broad treatment guidelines. 2 versus 3 drugs, 3 versus 4 drugs. What are the different categories we are going to choose from and why we are selecting certain options? What is the data to support them? Once we have come up with some decisions, once we have come up with some plans, I'll also make sure that they are very aware of the side effects to expect and what to expect with treatment, what to expect in the next 1 month, in the next 6 months, over the next 5 years, etc. But then I'll try my best to write that down in as much detail and simple language as possible in their notes. And I highly encourage patients to record the meeting or have a loved one, a caregiver on the phone if they were not present in person. And if they try making the notes, I'll tell them, let me make the notes, let me write down on paper, and I'll share this with you. And then you read my note, but I want your full attention as we are talking. Then typically, after the patient has left and gone home, there will be, once we have decided on a treatment, there will be an education visit during which the nurse will contact the patient, again answer questions, and hopefully within these 2 or 3 touch points, we've been able to answer questions. It is very difficult. I completely understand, and we don't have enough time, but that's also the challenge, and that's also the opportunity for us. And I don't know what maybe Dr. Cole can also help guide this even further.
Yeah, thank you, Dr. Ailawadhi. Those are great practices. And Dr. Cole, we'd love to hear from you about how you approach shared decision making. And maybe if you have an example where the patient's input meaningfully shifted your initial treatment plan.
Yeah, just like Sikander had mentioned, myeloma is complex, and for patients, it takes a lot of medical literacy to be able to navigate this disease. I mean, it's not, if you have melanoma, you can go. I always worry about I always imagine, what's my patient going to say when she goes to church? She has melanoma. She can just show them, here's my melanoma. If you have myeloma, then you have to be able to tell another person that you have a cancer of the immune system of a certain cell called a plasma cell that's inside the bone marrow, that I'm checking blood counts, and it takes a lot in order to get through that. And shared decision making for myeloma, isn't something that one day that I just walk into a room and say, we're going to share decision making today. It's a complete journey. And that journey, starts with the first visit. So I do exactly, what Dr. Ailawadhi said, that I actually have the patient information about myeloma. We start with what the disease is, and I actually write down a lot of the information, instead of giving them a brochure and saying, here you go, read this when you go home, I go over that brochure with the patient. And so I have my pens, they have their pens. I make sure that when it's a new visit, when it's those first couple of visits, that our scheduling people are sure to say, bring your family with you. Don't come alone. Bring somebody with you that can help with all the things that we're going to talk about, during their visit. And sort of so I go over all the details, and I tell them, my mom was an elementary school principal, and I know that it takes 3 passes, 3 exposures in order for you to really learn something. So I tell the patients, there's no pressure, there's no test at the end, that we're going to go over this again and again. And the goal set is that eventually you'll understand this disease as well as I do, and that we'll be able to talk, colleague to colleague, that we're not going to have this imbalance between, the patient and the doctor, but we work together. And the way to do that is really education. And that education doesn't take place on one visit. It takes place on every visit, every time. So I had a patient, just recently, and she's 90 years old with myeloma. I put her on Dr. Ailawadhi's clinical trial. So there you go. And how we got to that is that she came in with she came from a nursing home. We talked to nursing home, says the daughter has to come with her. Really has to, not just, they were going to send, the person with the nursing home, daughters to come with her. We sat down and went through myeloma 101, kind of, wrote down everything for her. And I asked her, one thing is, tell me something about yourself that's outside of myeloma. Tell me something that hasn't anything to do with this disease. So I found that she was a nurse, and she was a cardiovascular nurse for years. And so now we talk about that, her history. And I asked her, when on her second visit, about goal setting. And she said that when we talked about, options, she wanted to not have pain and she wanted to have more energy. And I said, well, here are the therapies that can get you there. And she was really interested in the clinical trial. She said, I want to help other people behind me that will come, that will have this disease in the future. That was very motivated for her. When I asked her about the goals of care, that was a very strong motivator for her. And so she decided to go on the clinical trial. I would have offered it anyway, but her motivation was definitely to go on the clinical trial. And now she is, there's been a few bumps in the road, but she's very happy with her care right now.
That is incredible. I love that both of you really talked about the humanity aspect of your encounters with your patients and the importance that they understand and getting to know them beyond their disease and making sure that they have the proper support during these visits. I really appreciate that. Well, we know that patients come to the table with lots of experiences and expectations, and all of those things can influence their preferences. So, Dr. Ailawadhi, how do you navigate situations where the patient's goals may not align with the evidence-based recommendations for their disease?
An excellent question. I'm so glad that we are having these discussions because we think about these things and we encounter these things, but we don't end up talking about these situations all the time. So it can be a little challenging because I'll be very frank. All of us have preferences of what we think is, in a way, might be beneficial for the patient. And frankly, doctors, medical professionals may have this kind of paternalistic view towards medicine. That happens very often. Similarly, sometimes patients have that similar view that they just want their doctors to take the decision. But at the same time, in this kind of focus on shared decision making, it is extremely important to understand where the patient is coming from, what are their beliefs, and why are those beliefs there. And frankly, if at some point, see, it's important to remember our job is to guide the patient, do the best for the patient within our knowledge, our experience, etc. But what I say all the time to the patients is, well, we're presenting these options to you. You're more than welcome to pick what you want. Let's discuss. If I don't feel that may be the best option for you, I'll put across my case. But that said, if you take a decision which complies with your beliefs, your knowledge, your understanding, and you've decided to go there, we will still fully support you. We will try our best to walk you through that decision in the most appropriate manner. And I'll give you an example. One of the very important treatments for myeloma today is CAR T-cell therapy. And I've recently had, maybe in the past month or so, had a patient who lives maybe an hour, hour and a half away from us, but has good family support and unfortunately has had disease that is progressing through treatment options relatively rapidly. So we had a discussion, virtual visit, and I laid out some treatment options, but I strongly suggested CAR T-cell therapy because there is a possibility that person may get a meaningful response with treatment. And the patient's first response was, nope, not going to do that. So, all right, let's try to talk about it. Nope, not going to do that. It took maybe a visit or two to get to the point that they were beginning to open up. And they opened up that the side effect profile was just extremely scary for them. They had read about it. It was extremely scary. It took a third visit, till the third visit, for me to try to convey to them enough that, well, all you're reading is not necessarily all that will happen. Things may happen, but this is the range within which we expect, and our treatment, our management of side effects is much better now, et cetera, et cetera. So I made my case quite vehemently, quite enthusiastically. But despite that, the patient actually sent a message to the nurse because they were not very comfortable saying it again to my face that they really didn't want to do that. So they sent a message to the nurse that, hey, we're not going to do CAR T, and we'll probably, and they canceled an appointment. So I actually then called the patient and I said, well, if you don't mind, may I speak with you for a few minutes? They said, yep, sure. I said, first of all, if by any reason you're canceling the appointment was because you thought that you were not going according to my recommendation and that would irk me or hurt my ego or make me angry, please, that's not the case. You don't want to do CAR T? We will not bring up CAR T, at least in the near foreseeable future. I'm not guaranteeing I won't bring it up, but I may bring it up in the future. But we can still take care of you. We can do a lot for you. Please, if you're okay about keeping the appointment and discussing alternative options, let's discuss alternatives to CAR T. We have many, many things we can do for you. That made a difference in which the patient then set up the follow-up appointment with his spouse because he wanted her to be there. And we discussed options, and now they're going to start some other treatment. In fact, I made a plan that they're going to be getting with their local doctor so they don't have to come an hour and a half back and forth. But frankly, bottom line is that the patient's choices, preferences, beliefs, goals, as Dr. Cole also mentioned, are paramount. And it's important to be able to convey this to the patient. Our job is to guide. Our job is not to dictate. Sometimes we will come across these situations that the patients are taking a decision which may not be the best based on evidence. But if we really try to think about why the patient is taking that decision, I think that may be the best decision for that individual.
That's such a great example, Dr. Ailawadhi. Thank you for sharing that, and even for being vulnerable and sharing with us how things kind of didn't quite go as well, and then you were able to get the patient back on track. Well, speaking of CAR T therapy, Dr. Cole, I'm going to address this question with you. Do you have any similar stories, or have you identified communication strategies that have been effective in improving patient comprehension and engagement around some of these newer treatments like CAR T?
Yeah, that myeloma isn't curable yet, right? So, everyone at some point is going to have a relapse. And so, right, when I say to a patient, you'll know this stuff as well as I do, once they kind of got, settled into their induction therapy, once they got settled in, the one thing that we do is that we talk to the patients about the new therapies. Because after they kind of get settled in, now they're kind of curious about, what else is out there. So even when a patient is on maintenance therapy, there are people on maintenance therapy for years, and their visits can be pretty straightforward. And I use the opportunity, during those sort of quiet time visits to talk about new therapies. So so a lot now my patients come in, I walk in the door and I say, what's new in myeloma? And I mention the CAR T, and I mention, under very, very easygoing circumstances. I could walk in, say, how do you do? How's your maintenance? I could walk out. But I sit down and I talk about these new therapies. So I talk about, these are the new bispecifics, or really, you don't need it now, but this is how they work. There's the side effects. Then they come another visit. A couple months later, we talk about bispecifics, talk about how they work, encourage them to go to some of the meetings. The patient support meetings, they talk about this and hear it from other patients. And I kind of lay the groundwork because, I can't go home and talk about the new myeloma therapies with my wife because she's heard it for 20 years. And if she doesn't want to hear any more about myeloma, bless her heart. And so I talk with my patients. So then when the day comes that they actually have relapse and we're talking about bispecifics, clinical trials, or CAR T, it's nothing that's foreign. I mean, they've heard this over the course of years. And so patient empowerment isn't, like I mentioned earlier, patient empowerment isn't you walk in one day and say, hey, it's time to be empowered. It's a journey. It is a practice style that just like you practice piano and practice guitar, you practice patient empowerment every visit, every day. And I think about that when I go and see a patient. Have I engaged this patient so that they understand? Because if they don't understand what I'm talking about, it's not on them. That responsibility is solely on my shoulders. So if they say, I don't understand what an M protein is, then I have failed at doing my job. And I need to up my game a bit to make sure they understand that. And so it is really, it's a journey over time to empower patients and to know about their options, even when we're not engaging them on that visit.
Well, each of you have described just some really amazing ways that you interact with your patients and the personalized care and the conversations and the writing of the notes. And the thing that I'm struck by is that we all know there are very limited time that most physicians have to spend with their patients. So I'm curious, how are you doing this with the limited time? Are there certain strategies that you've implemented from a system level? Are there things that you would like to see adopted? And I'll have you share one, Dr. Ailawadhi, and then I'll go to you, Dr. Cole.
So you're so right. In this time-constrained world where we have double, triple booked meetings on top of clinic and then grand rounds or tumor board and this and that, it becomes very difficult. So I think the first thing is that as an individual, or even I would say for my institution, the guidance that we follow is when I'm in front of a patient, I have to leave everything else at the door when I enter that room. So in that particular visit, nothing else matters. It is only that patient and everything related to them. That said, I shared an example earlier where to get to one treatment decision, it took almost 4 visits. And that's the reality of the world. So at least in our system, how we have it set up is that this barrage of messages and in basket and information, etc., that comes, it is screened at a few tiers So messages that are related to medications, etc., there are clinical assistants who are constantly dealing with that and taking care of that. Clinical questions are typically being handled by our nurses for the pod. There are 2 of them who handle all the questions that come and are clinical and can be handled. At the next tier is that if they have any need for a clinical decision, they will first go to the APPs in the team, the advanced practice providers, which actually I should say one of the things we have implemented is the whole team sits together. So there is about a 5-step radius between me, my nurse, the nurse practitioner, the physician assistant, the scheduler, the research coordinator, everybody sits together for the clinic. So that helps that communication. And if they are not able to get the answer with the APP, or if it's a very specific question which I must answer, it's a treatment related guidance or a change in management or an urgent message, then I will be involved in that. So I think we have this tiered work which or a process which tends to work good. There are some tools that are being implemented. I personally don't use that, but there are AI tools for documentation. For example, when we are with the patient, the notes are almost finalized before even we leave the room. So those AI tools really help with taking away some of that documentation burden. So I'll stop with these 2 examples, but over to you, Craig.
I need one of those. The well, one thing, I loved everything that you said, and we kind of do some of the same things. That it's kind of tiered. That I'm not, when a patient is ruined, I'm not the first person that they've seen that day. And some of the questions have already been, they may have, or concerns or problems have already been screened by like our pod nurses too. So when I walk in, if they're having a problem with their central line, that, that's being taken care of in the background while I'm with the patient. And so I think, for some of the complex patients that I just ask, some of the patients on maintenance therapy, I don't ask the nurse to really go in and see them, but some of the more complex patients, the pod nurse will go in and kind of screen through to make sure that everything's okay so I can be prepared, which then streamlines things. The other thing is I make sure that I tell patients, write down your questions. Come in and write and have your questions set. Because it will streamline instead of patients kind of humming and hawing and saying, "Gosh, what was I going to ask you?" I think the biggest thing which has really helped is I congratulate patients when they bring in their notes. I say, "Those were fantastic questions. I'm so glad that you wrote them down," which then encourages them to do it again. And then it really, I have one patient, bless her heart, and she always has, I think she works really hard at making 20 questions. Because some of the questions like, 17, 18, and 19 are just, they're definitely filler questions, but her magic number is 20. So we just hit, 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 hit. And usually, and I say, make sure you incorporate questions about how you're feeling and what you're doing now and how you're doing now as part of our visit. And it streamlines things quite a bit. And sometimes I ask to make a copy of their note, of their questions. So when I make my note, I have, at least a template of some of the stuff that we talked about. But, having an organized visit as much as you can with a patient. Of course, there are going to be things that kind of, catch you by surprise. The other thing is just like Sikander said, I'm a very, very timed person. And I'm always thinking, gosh, I'm running late, but I'm with the patient. I encourage my patients, and when I do talks for patients, I say, slow down your doctor. If your doctor's running too fast, slow them down. I even tell my patients that if I'm going too fast, slow me down. So all my patients know that I run a little late, sometimes a lot of late, but they know the reason I'm running late is I had to spend time with somebody, and they're very very understanding for my tardiness.
That is wonderful. Thank you to both of you for such a rich conversation about engaging patients and their partners. So now we're going to shift to talk to our healthcare provider audience about best practices and real world strategies to reduce treatment burden and optimize outcomes. And I'm going to start with you, Dr. Ailawadhi. As the therapeutic arsenal for myeloma continues to grow, how are you and your team proactively addressing treatment burden, whether related to toxicity, visit frequency, or logistical demand, so that your patients are adherent to therapy and also having quality of life?
So, extremely important question that you raise. Treatments are clearly becoming very complex. The needs on the patients, the needs on the caregivers, the needs from the practice, from us, from our staff, they're just increasing tremendously. I mean, literally, our nurses had to be trained how to handle CRS-related calls, how to handle neurotox-related calls with all these new drugs, etc. So it's required a lot of that training of our staff, our side first, to be able to handle all the anticipated and unanticipated asks from the patients. That said, I think the goal, and I think this is something that as a myeloma community, all of us have to spend time on, is try to, like you rightly pointed, decrease the treatment burden. I would say decrease the burden on our patients collectively. We have several drugs that have been now approved where we're still learning how to use them. None of us in the medical community feel that those drugs are optimally dosed or optimally frequent, their frequency is optimal, etc. So I think in the day-to-day work, what we're doing is providing tons of education and awareness opportunities for patients and caregivers to try to arm them with as much information as possible prior to starting a treatment, so preparing them. We have an effort going on which is a little bit tricky and difficult, but almost giving an informed consent type information to patients and caregivers when they are even starting standard of care treatment. Because just preparing them, we don't do that for standard of care. We give tons of information for trials. We just don't give that much information for standard of care. We have certain videos that have been prepared, and we share those. We host those on YouTube, for example, and we share those with patients and give them links saying, "Hey, watch this, see this. It'll help you understand, etc." We're also planning some. So I think we're trying to harmonize our own practice, where we're trying to say, okay, at such and such intervals, as a group, we have decided we will do XYZ testing. Based on that, we will discuss with the patients the current data, and if need be, we will space out their treatments so their visit frequency decreases, etc. And then at our institution, we also have at Mayo Clinic, we also have this opportunity for what's called remote patient monitoring. So all our patients who start on treatments like bispecifics and sometimes even CAR T patients are kind of connected with our remote patient monitoring infrastructure, where they don't even have to come in that frequently. And of course, they don't have to stay in the hospital. We treat all our bispecifics outpatient. But by doing those things, we're trying to reduce their burden for having to deal with the treatment and its impact. I mean, we want the patients to feel better. We want them to have improved quality of life. And frankly, we want them to stay home when they don't really need to be out of the home. So we're trying to gear an infrastructure. We're really far from being perfect. I think in a myeloma community, all of us are far from being at that optimal state, but slowly, gradually, we're making progress towards it.
Thank you so much, Dr. Ailawadhi. Dr. Cole, kind of staying on this same topic, when we think about patients who are receiving multiple lines of therapy, or maybe those who are experiencing functional decline, how do you adjust your strategies over time to engage with those patients?
Yeah, it is, as patients kind of go through their journey, and as they go through treatment lines, I am sure not to assume that the treatment goals that we had 10 years ago are the same treatment goals that we have today. And so we have these periodic, when I'm meeting with my patient, meeting with their family, we reassess, what are the goals of treatment? I had a patient with high risk disease that had come in to see me a few years ago, and their goal was, I want to be MRD negative, and I was like, okay, we have studies, we have therapies that can try to achieve that goal. And then later on in their, years later, after a couple of relapses, we talked about, what was the goal, and their goals had shifted. At first, their next therapy after they had failed a CAR T, could have been, more aggressive this, more aggressive that. And I said, so, with everything that's been happening, what's your current goal? What do you want out of the next decision that we make? And they said, really, I just want to have enough energy to go to my granddaughter's graduation. And it wasn't so much, being MRD negative, but it was very different. And so we de-emphasized a lot of the lab tests, the M proteins, and started really working on that aspect, and which included involving a lot of palliative care and in their during their treatment journey. And I think one important point is that, involving the team shouldn't be a surprise. When the team walks in the room with me, it shouldn't be, oh my goodness, I must be dying. It's yes, I met the social worker. Yes, I met the palliative care doctor years ago, months ago. Yeah, I know these people. And when the goals have changed, enacting the multidisciplinary team, isn't such a surprise. And it makes that a much more comfortable goal, a transition, and is not a surprise. A lot of patients say when they see palliative care, they never met them before. That can be really frightening to meet a new person like that in that situation. Well, they've met them before, they have rapport already, then it's not such a bad transition. And then all of us, we circle the wagons around what that goal is. And I tell my patients, that may change in a few months. I mean, in a few years, your goal, but make sure you verbalize that to me and make sure that I always ask that.
Thank you so much, Dr. Cole. Well, as we prepare to wrap up, we're going to talk a little bit about treatment priorities and how they may differ between patients, their care partners, and their clinicians. So, Dr. Ailawadhi, in your experience, what are the most common differences in treatment priorities that you've encountered? Maybe you can share one example and how you successfully navigated those challenges and those situations.
Sure, absolutely. So there's actually, I think in myeloma, we're lucky to have some of this in this question even supported by research. So there have been a couple of studies now done, one through the IMF even, where they looked at the doctor's priorities and the patient's priorities. And there is also some similar work that Dr. Cole and I actually have been able to collaborate on together and present at ASH a few years ago. And it seems that the doctor's priorities are always very different from the patient's. The doctors are always focused on this primary objective, secondary objective, PFS, OS, response rate, MRD negativity. And majority of the times, while the patients do want to live longer, please don't misunderstand me, but the focus on quality of life, the focus on symptom control, the focus on burden on the patient and their caregiver and the family, et cetera, is paramount and weighing them down all the time. So I think trying to understand, which I think Dr. Cole mentioned very nicely, is to trying to understand that patient's goals. What are they looking for in the treatment? And trying to meet them at that level becomes extremely important. And if I was to give another example of specifically where things changed, I think Dr. Cole mentioned, for example, a graduation for a patient's family member or child, or in I've had similar experiences where we came in with treatment options. So I'll share with you, there is one patient, very dear patient, where it's been a constant struggle to figure out the treatment options for that person, because to me, she may look like a myeloma patient. But when I try to dig deeper over these past maybe 6 or 7 or 8 years I've known her, she is a grandmother who has custody of her grandkids and is taking care of them. She has her own daughter who's going through some medical and family issues of her own, so cannot take care of the grandkids. So, her kids. So this patient of mine has custody of all her grandchildren. She lives about 30 to 40 minutes away from where we are, so the distance is a constraint. I've tried my best connecting her with their local community hematologist, but somehow that didn't work out for her, so she insists on coming here. So on the face of it, while our team talks about, oh, it's so difficult to get her to come, or oh, so difficult to check labs, it's so difficult to do this or that, I've been discussing CAR-T with that patient for the past almost a year. We have never been able to do that for the simple reason logistics don't line up. So finally, we said, okay, why do we even keep talking about CAR-T? This is the ideal patient who's going to go to the bispecific antibody as long as we can get her to that. And so we are tailoring the treatment plan to that patient's goals, because while she wants to live longer, she wants to take care of her grandkids. She wants to be able to stay at home as much as possible, provide some medical care to her own daughter while getting herself treated. So I think understanding these goals and trying to tailor the patient's treatment with all our knowledge and all our biases and all our preconceived notions and this and that. The bottom line is that the needs of that patient must come first. And whatever the literature, the this, the that, the articles, the trials, that has to all conform to that one patient's need at that moment.
Absolutely. Thank you so much. This has been an amazing conversation. Unfortunately, it is time to wrap up. And I want to have you all give you all the opportunity to share closing thoughts. You shared so many important tips today, so many things that the audience will be able to take away from this conversation. But if you were to summarize it all into one closing thought, and I'll start with you, Dr. Cole, what's the most important takeaway message that you want to leave other healthcare professionals who are watching?
No, and thanks for the opportunity. This is a passion of mine, and what I hopefully get across to our fellows and our residents is, no matter what the discipline, no matter what, no matter if it's, no matter what the field of oncology, these are really, really important things to incorporate in your practice. And I think the one thing is that patient empowerment and patient education is not a one-time event. It is a style of practice. It's something that you do every visit, every day that you see a patient. And the question I always ask myself is, have I empowered this patient? Are they engaged to this disease? And I never blame the patient. I always, take a look inward if I'm not achieving those goals. So my takeaway is, know your patient, know who your patient really is. Just like Sikander said, she may be a myeloma patient, but she's someone's grandmother and primary caregiver. Knowing those details goes a long way in patient care and patient empowerment. That levels the playing field between you and your patient so that your partner is in the journey and it doesn't have, a paternalistic dynamic.
Thank you so much, Dr. Cole. What about you, Dr. Ailawadhi? What's your closing take-home message for the audience?
So, Dr. Rochester, again, thanks for this opportunity. I think this has been a great discussion. So I think my thought, quite similar to where Craig mentioned, I think, as you've pointed out a couple of times in these questions, that the treatment and management of myeloma is becoming very complex. And when we try to say on top of that, we have to reduce disparity, we have to improve shared decision-making, we have to give the patient time, we have to empower the patient, we have to educate them, the patient should know what questions to ask. There is so much of this competing thoughts with constraint on time, staff, etc. My thought or my suggestion to our colleagues who are listening out there or spending time, and I thank them for spending their time listening to this program, is that it's probably a good idea to take a step back, think of all the barriers in the ways of that patient, in the ways of a physician, in the ways of that practice. Try to list all those barriers and start somewhere. Start making some changes in your workflow and your practice and how you see the patient, what you talk to the patient. We are, I would say, blessed that one, the field is improving, but we also have several better tools, AI tools, communication tools, etc. So once you have an inventory of the barriers, start chipping away at them. And slowly, gradually, you will start seeing incremental improvements in how we are empowering the patient, but also empowering the practice, empowering the physicians, the healthcare providers. I think it's important to help them start somewhere, and hopefully incremental changes will make that bigger, meaningful difference.
Well, thank you both for just everything that you've shared today. I feel like if I were to summarize this conversation, you all really talked about the art of medicine. There's the science of medicine and there's the art of medicine. And so you all have really just articulated the art of medicine and the importance of connecting with patients and meeting them where they are and getting to know them as people outside of their disease. So thank you again for this riveting conversation. And thank you to those of you who are tuning in to this Empowering Providers to Empower Patients program. I'm Dr. Nicole Rochester. Have an amazing day.